I have to admit to a bias. And the first bias that I'll admit to, and I probably have lots of biases, but the first one that I'll admit to in public is that as a former educator, professor in a university, editor-in-chief, I think the answer to this question that you see before you, what we know and is the literature credible, my bias is yes. We look at the literature as credible, and so during the course of the next 45 minutes or so, I'll try to convince everybody in the room that there is pretty good credibility in the dental literature. That's not to say that it's perfect, and I'll probably try to demonstrate some of the warts that are present in the dental literature, because it's important that we realize that it isn't perfect, that there are some variabilities to it. So what do we know about dental implants? If we think about dental implants, we realize that these are devices that provide support for dental prostheses. Without the implant, the prosthesis has to look to other means of support, mucosal support or tooth support, and both of those have very potential or very large drawbacks from time to time. We realize that dental implants tend to be very predictable. Medium-term survival, somewhere in that 1 to 5 year range, is about 94% or greater across the board as we look at implant articles in the literature. As we listen to presenters, those numbers are pretty consistent, 94% or above. Pretty much regardless of the manufacturer of the implant, pretty much regardless of the type and design of the implant, implants indeed work. And for us, it becomes this decision of using implants that work in our hands, because there are nuances to every different implant system, every implant design, and it behooves us to very carefully assess the ones out there that we're going to use in our practice on a day-to-day basis. We choose implants quite often because there are fewer biologic complications associated with implants. An implant's never going to develop dental caries. Pretty obvious. But we're also going to see fewer problems related to fracture of implants in comparison to natural teeth. We're not going to see periapical involvements on implants. So there are a number of biologic complications that we see in the natural dentition or in the restored dentition or in the mucosal-borne dental prostheses that we simply don't see in implants, or at least not at the same magnitude. And the key, I think perhaps the most important thing that we'll say here, is that if we follow the formula, implants succeed. There are a lot of formulas that we can use in complete dentures. I happen to be a co-author of the largest selling complete denture text in the world, which some of us in the room may remember as Swenson's Complete Dentures. Eventually it became the Boucher Complete Denture text, and now it's just, I can't remember what the title of the text is, but George Zarb is the primary editor. I happen to be one of the others. And if you look at that denture text, what you'll find is that the formula for successful denture therapy is really complex. It's not a simple formula. It's not something that's straight and direct. There are many, many different approaches that we can use, and often they are very dependent upon this right here, what happens in your hands. If we look at implants, it's not necessarily what happens here, it's what happens here. Our ability to choose appropriately, to utilize appropriately with implants makes a huge difference for us, and it takes away a lot of that variability that we often see with traditional techniques. So what is the formula? How do we control the factors that we need to control to make sure that implants succeed? And those fall into different categories. We have patient categories, we have implant-specific categories, and then we have surgical and prosthetic categories. And we'll try to look at each of those. From a patient factor standpoint, we realize that we have to have a favorable host. We have to have a healthy body that we put implants into, or a healthy bone that we put implants into. That bone has to be healthy. It has to have adequate volume, adequate height, adequate width. Has to have adequate density. And the patient that we supply with dental implants has to be psychologically predisposed to having something foreign in their body. It's amazing how many patients will look at a foreign object in their body and simply not be able to cope with that notion that they have this foreign thing inside them. We have to choose very carefully. We have to make sure that those patients who are going to be worried about that sort of intervention, that we don't provide that intervention that's destined to fail if they're psychologically incapable of adapting to the dental implant. We have implant factors. Today we think about dental implants and we realize that we basically have an industry centered around titanium and titanium alloys. We have titanium in various levels, 4 levels of purity, commercially pure titanium grades 1, 2, 3, and 4. And they're all about 99% titanium, plus or minus a little bit of other elements. Then we have the traditional 6-4 alloy, 6% aluminum, 4% vanadium, and we have the zirconium alloy with titanium. We realize that there are certainly other implant materials that will be coming and going over the years. In the past, we had aluminum oxide implants. Worked pretty well for a period of time, but eventually ran into fracture issues. We've had discussions and implants introduced into the market that are commercially pure zirconia implants. The surface is very favorable. The integration seems to be quite good, but that issue of fracture and fatigue becomes an issue that always becomes a consideration. We can look at the periodic table and we can see where titanium is, and we can draw a little circle around titanium and some of the other elements, and we can think about future avenues of research because maybe there are other materials that will be as good, if not better. And it certainly demands ongoing investigation. Then we look at the design of the implant. Macroscopically, most of the implants that we use today are threaded. There have been implants that have been used that were not threaded. Cylinder implants had a very good start back in the 80s and did very well and were promoted very highly for a period of time, and then the interest sort of fell off in favor of the threaded implant designs. And then the implant surface, we certainly are aware that there are lots of different surfaces that are available in the marketplace. Surfaces from the traditionally described as smooth surface, which was never smooth, it was just machined in a anisotropic manner. Consequently, there were sort of parallel grooves, and the peak-to-valley ratio of those smooth implants was pretty much the same as the peak-to-valley ratio, the RA or the SA values, as were the initial implants that came out in the micro-textured or micro-roughened surface. Today, the industry is pretty much managed or pretty much run by micro-textured implants. Today, they're doing very well. But there are always these questions, is that going to be the same design that we will use macroscopically and microscopically over the next 20, 30, 40 years? And it's something that we constantly need to reassess to ensure that we're on the right path. Surgical and prosthetic considerations have been handed down for many years now to us. We know that when we're doing implants, the surgical intervention needs to be gentle. It needs to be controlled. It's not the wild, wild west, the days when a clinician would take a high-speed hand piece and cut a groove in the mandible and hammer in a blade implant. Those days are long gone. It's become a gentle, controlled process, and it becomes one that the tissue needs to be considered, needs to be not violated, not beaten, not traumatized. The critical temperature of the bone needs to be always something that we're aware of. We need to prevent ourselves from exceeding that 43 degrees centigrade temperature. And early descriptions talked about surgical closure And today we still look at surgical closure and how we manage the soft and the hard tissue to keep everything working well. This idea of rigid fixation, today we talk about implant stability and we talk about lack of micromotion, but it all comes back to the old concept of rigid fixation or the avoidance of microtrauma that could prevent bone from healing to the implant in the early stages of osseointegration. When we think about dental implants, we talk about reduced risks. We know that the literature has told us about anticipated survival of the implants and anticipated complication rates, and the dental literature is where this information needs to come out. It needs to come out in scientific journals. It needs to be something that we are constantly aware of and constantly reassuring ourselves that we're making progress at making things better and better and better. One of the big advantages that we have in the scientific literature is that we have a broad distribution of clinicians and a broad distribution of patients that allows us to generalize our opinions about the intervention that we entertain. The broader the number of clinicians and the wider the population base that treatment is provided to, the more we're able to say that indeed this will work in South Africa, it'll work in Australia, it'll work in Asia, it'll work in North and South America. Because if all we did was to look at implants in Switzerland or implants in Germany, and if those implants were only done by 20 clinicians, our ability to generalize information would be very, very limited. Because I don't happen to live in Switzerland or Germany or Sweden. And because I don't live there, my population base is probably a lot more diverse than a Swedish population base. And my clinician colleagues are going to be a lot different in their training, in their background, and perhaps in their skill set. So all those things go into our ability to generalize information. We know that we have appropriate comparisons of data within the literature that allow us to compare, perhaps not side by side with other treatment modalities, but perhaps we have to look at literature coming from one source and compare it to literature coming from another source. So if I only look at prosthetic literature, I miss out on periodontal literature. I miss out on endodontic literature. I miss out on oral surgical literature. Combining some of these things and looking in only implant literature allows me to get a better perspective quite often relative to what is out there, what's across the spectrum. We know that implants provide us a level of predictability that we simply don't see in some of the other areas of dentistry. The literature helps us determine what our anticipated results are in the implant field. The other thing that I think is very critical for all of us is to keep our own data. It doesn't matter to me that Dr. Cochran can show great data in his patient base if I can't achieve those same numbers. Maybe my data are better than his data. It's always possible. And that would be nice information for me, but it would be irresponsible of me if that were the case to switch my techniques to mimic his if I'm doing better. And the only way that I know if I'm doing better or worse, whether it's time to change or whether it's not time to change, is by looking at my own results day in, day out. I should be able to, at virtually any point in time, give you an estimate of what my implant survival rate is, because that becomes that critical factor relative to what we do about changing techniques or embracing new technology. The current experience that we have is going to help us predict the future. It's going to help us predict the need for future investigation, for future research, and for future change. I would suggest that published data assists us in that decision-making process, but just because something is published doesn't mean that it's always right, that it's always true. We have to be very careful, conscientious consumers. So where are we in dental implant literature? It compares favorably with other dental interventions, but of course that means that we need to know about those other interventions. I can't ignore the endodontic literature. I can't ignore the restorative dental literature on top of root canal treated teeth. I have to be aware of that. What are my chances of something lasting 3 years, 5 years, 10 years? Because if I don't know that information, how do I choose a dental implant as a superior alternative or as an equivalent alternative if I don't know what it's equivalent or superior to? I would suggest to you that when you go to a presentation like this meeting or any other continuing education meeting, there's always a potential that the oral presentations can be biased, and it's quite frequent that there will be industrial sponsors that bias information in one direction or another, or that there are financial motivations for the speaker that bias information in one way or another. When I give this presentation, there's no peer review for it. I didn't run it by a group of 3 reviewers to ask them to tell me whether I'm doing the right thing or presenting the right information. You know, a lot of the presentation comes off the top of my head. Hopefully, there's something in that head that helps make the information somewhat valuable. May not be the case. We need to avoid the tendency to avoid presentation of negative results. Did that make sense? It was a double negative. We need to present negative results to a group. We can't be afraid to present negative results. And that notion that people avoid presenting negatives stops progress. And it becomes very critical for us to always be willing to, open our wounds and show everybody that these are indeed things that sometimes do not always work exactly as promised. Dental implants are less skill reliant than our traditional procedures. The literature presents us the scientific results. We realize that quite often, especially in university settings, the treatment is provided by less skilled, less experienced students. And yet those results, if we have selected our patients wisely, if we've applied appropriate inclusion and exclusion criteria, those results remain valid for us, and perhaps may be more valid in some instances simply because we don't have the uber-skilled clinician in whose hands everything works. Students make mistakes. Sometimes those mistakes are valuable to us in terms of predicting in a more general sense what treatment outcomes might be. And I think it's always critical when we're looking at literature to evaluate those inclusion and exclusion criteria and make sure that what has been excluded from the published research is what I might exclude from my own research or from my own patient treatment. If we've eliminated all risk factors, we have to look at our own practice and say, do we do the same thing? Do I treat patients who smoke? Do I treat patients who are diabetics? Do I treat patients who have had bisphosphonate therapy, radiation therapy? Yeah, I treat all those patients. And certainly when we look at this issue of what is published in the form of efficacy, where it's an idealized treatment approach, sometimes that creates results that we may not be able to match in our clinical practices. So what about the literature? What I would suggest is that literature provides us a consistent method of reporting. And we know that every article that we read, by and large, has this list of sections to the article. Every article has an introduction. It gives you some background into what information is out there, what's out there and available on this specific topic. As an editor, I can tell you that quite often I'll receive submissions where the introduction is like 8 or 9 pages long. It's not a PhD thesis. We don't need 8 or 9 pages of introduction. We need to focus introduction. And if editors are allowing 9-page introductions into the literature, to me, they're not doing their job. It becomes critical that they indeed do their job. Force the author to focus in on what is pertinent and relevant to the specific article that's being presented. Give a purpose. If you read an introduction to an article or you read an entire article and you can't tell why the author wrote it, that's a big problem, isn't it? You know, we need to know what the purpose of the research was. It should be clearly stated, specific aims or a purpose statement. If you don't see it, I would suggest that you might want to stop reading right then, because if no one has articulated the reason for writing the article, it's going to be hard for you to truly understand it. It means that you have to interpret a reason rather than know the reason. And it's really good if you know it rather than have to interpret it. The other sections, materials and methods, results, discussion, conclusions, all become very formalized sections to a scientific article. They should be very clearly delineated, and it should be very easy for a reader to understand what information belongs in which section. So throughout this room, some people are going to be real materials and methods folks, you know, that they'll read the materials and methods in an article first. I would suggest that first they should look at the purpose, but then as soon as they've done that, then they go to materials and methods to see whether they agree with what was done or not. Other people just go right to the conclusions. You know, get to the chase. Cut to the chase is the description in Hollywood, right? Well, that's okay, but when you read the conclusions, you need to then understand how you got to those conclusions. So then you double back to the results, you double back to the materials and methods, and see if there was something that was preordained in that research that dictated how the results were going to come across. Dental literature has the process of peer review. So what we do is we select experts, people who have had experience or have written on various subjects in the past, and we ask them to comment on the current research that's being presented. So the expert reviewers have to have this background information, and sometimes in the editorial world, we'll get articles submitted to us that are so complex or so focused or so cutting edge that there may be no experts. And that becomes a problem. It becomes a problem because the cutting edge researcher really wants to get their research out there, and sometimes you can ask 20 people to review an article and every one of them will say, you know, I just don't have the knowledge to make this review, to do it well. And that's sort of scary, because to get 20 responses, sometimes it'll take you 6 months before that happens, and all of a sudden that author who had cutting edge research is now 6 months behind in the publication process. This knowledge and experience basis is very helpful for the reviewers. I would suggest to you that when you get a request to review an article, consider it an honor. An editor has looked at you and said, I think that your area of expertise matches with this article, and I trust your ability to review it in an unbiased, scientific way. So not only is it an honor to participate, I think it's a necessity to participate. Next time you write an article, what you want is to have someone review your article right away. Someone with experience to say, yeah, I'm happy to improve the science. I'm happy to see this move forward, and I'm going to devote an hour or 2 or 3 of my time to reviewing this article to see that this information gets out to the public, or if the information is all hogwash, to keep it away from the public, because sometimes that's necessary also. The editorial process is one where I, as the editor, review basically every submission that comes into our journal. So JOMI's the largest circulation implant journal in the world. And we get about 500 new submissions every year to the journal. We have a variety of different categories of that journal, and we have a variety of guidelines that are required for submission to the journal. It's always interesting when someone submits an article to the journal and you read the article and you say, have they ever read an article from this journal previously? Yeah. If somebody just starts free-form writing, they're not writing the great American novel or the great South African novel. It's a formula. And they need to follow the formula, follow the guidelines, and that makes the whole review process go better. I review for general readability. Many articles are sent to us where English is the fifth language of the author. And it's hard to write in English. I mean, we have lots of countries throughout the world who speak English, and we still don't understand each other speaking in the same language. Imagine what it's like when you're speaking in a language that you never even started to learn until you were 30 years old. So general readability becomes a very important factor for us. We need to make sure that articles fit into the categories of the journal. In JOMI, we have the categories of implant science, clinical applications, technical and case reports, and now we're having a tissue engineering section develop in the journal. So those have become our 4 categories. So if someone writes an article that isn't any of those things, it's a show and tell article that doesn't really fall into the case report category. Maybe they're doing something that is pure technique. And ours is not the journal for that sort of article. Doesn't mean the article doesn't have merit. It means that they just selected inappropriately. So when you're going to write an article, always make sure that you have a good feel for what journal you're writing to and what sort of things that they publish routinely. I have to make sure that articles are not only scientifically valid, but scientifically interesting. So if I receive a submission on Monday morning about subperiosteal implants, and it might be the best subperiosteal implant journal article that's ever been submitted, I may still reject that article on the basis of no one does subperiosteal implants anymore. It may not have scientific interest to the community, and if that's the case, it's probably not going to get published in the journal that I happen to edit. Other editors might have a different view of that. We use a set of submission guidelines, and they're not my guidelines. They're guidelines that have been established by a group of medical journal editors throughout the world. And they're published. You can go onto the internet and you can find the Vancouver group of medical journal editors, and you can see the explanation of why each section is written the way it's written. I don't want to publish, or I don't want to see PhD thesis articles published in their entirety in JOMI. Pretty soon we'd be down to 2 articles per issue. We have a lot of things to get published out there, and we'd rather have a bigger variety. So we ask folks to follow these guidelines created by medical journal editors and make sure that they get their information out in a clear, concise, and informative way. If you're submitting an article to us, don't violate the guidelines. Read the guidelines. And if you have any concerns about the guidelines, send a letter to the editor. It happens. We receive them all the time. And say, can you share with me the guidelines for submission to your journal? Because I don't want to write an article. I don't want to spend 20 hours of my time writing an article and then find out that I followed the wrong guidelines. I followed the guidelines of Clinical Oral Implant Research, a very good journal. And I didn't follow the guidelines of JOMI, but I submitted the article to JOMI. So you have to make sure that you're following the guidelines of the appropriate journal. Be consistent in the terminology that you use. Every journal out there has some sort of dictionary or glossary or list of accepted terms. In JOMI, we use 2 different glossaries. We use the glossary of prosthodontic terms, and we use the Glossary of Oral and Maxillofacial Implants. Fortunately for all of you, the Glossary of Oral and Maxillofacial Implants happens to be a download on the ITI net, or ITI.org. It's somewhere in there, and you can find it and check terminology to make sure that you're using consistent, accepted terminology. Don't coin new terms. You know, everybody wants to be the person associated with the next peri-implant something or other. You know, that when somebody talks about peri-implant reinvigoration, they always say, Steve Eckert wrote that. Wouldn't that be cool? That everybody would say peri-implant invigoration and they think Steve Eckert. Now, don't do that. Don't create new terms. It just serves to confuse the public because the public may not accept the term. You may see it one time. You may not completely understand it. You may never see it again. It hasn't helped the industry. It hasn't helped our scientific knowledge. Don't use jargon. Try to speak clearly, directly, concisely. Make it simple for the reader. We're not writing at a college PhD, university PhD level. We're writing for 11th graders. Sadly, in dental school, we probably never are forced to read at anything beyond an 11th grade level. So we need to realize that jargon simply confuses. Keep it out of our articles. I would suggest that the policies that we use improve understanding and improve communication. They make it easier rather than more difficult for clinicians to review literature. There is a list of evidence, what we call an evidence-based hierarchy. And at the top of that list are the best studies that we can think of to avoid bias in research. And that would be called the randomized controlled clinical trial. The randomized controlled clinical trial is great research when we can control variables, when we can exclude things that need to be excluded, when we can include things that are clinically relevant. They're good trials for things that aren't dependent upon clinical skills. So if I'm doing a pharmacologic study, it's pretty easy for me to choose a control, which might be a gold standard medication for the treatment of a specific disease, and for me to introduce a test that we compare to the control. And I am the only person who knows whether the patient receives the control or they receive the test medication. Compliance is easy. The patient takes the pill. And follow-up and analysis is pretty easy because we see whether it worked or it didn't work. But there are a lot of drawbacks in implant research because if I ask a clinician who is highly skilled to do a procedure that they've done for the last 10 years, and then on the next patient say, okay, well, this patient was randomized to the other treatment arm, now you have to do a procedure that you've only learned 2 weeks ago, how do you think that's going to affect their ability to get positive outcomes with one versus the other? That skill level becomes a major black hole, if you will, in the randomized controlled clinical trials. And it's one of the reasons that although it's a great study design, we sometimes fall out of love with it, and sometimes that's the appropriate thing to do. When we look at grading of evidence, we realize that we can achieve or we can assign grades, A, B, C, D, just like elementary school, to the evidence that we have. So if we have consistent evidence from good study designs, that gets to be A-level research. If we have less consistent information coming from good study designs, that might fall down the grading levels. So we can assess on the basis of what we see published out there, whether there is agreement or whether there's disagreement, and that tells us how confident we should or should not be in the information. But it all comes down to one word And that word is bias. Because all of this hierarchy, all of this grading is all done to evaluate the potential for information to be or to not be biased, and we'd like it to not be biased if we can avoid it. So here on the left-hand side of the screen, you see two terms, systematic bias and random bias. Systematic bias, it's like a bias designed into the study. Okay? Systematic bias is bad. That's bad bias. Random bias is just bias that just appeared without any planning, without any forethought. Sometimes folks who talk about evidence-based medicine or evidence-based dentistry will describe that as background noise. So random bias is a lot less troublesome to us than systematic bias. On the right hand of the slide, you see some examples of sort of systematic bias. We'll talk a little bit more about bias. There are certainly alternative methods of sharing of information. It doesn't all have to come from scientific literature. Think about our dental education. You didn't read journals in dental school, did you? You read textbooks, you read workbooks, different clinical manuals. So everything was very procedure-oriented. You go from step 1 to step 2 to step 3. Only when we've completed step 1, then we move to step 2. Only when you complete step 2 or master step 2 do you move to step 3. General education, very, very structured. Sort of like being in the military. We have textbooks. And I'd love to tell you that I've edited textbooks and wrote for textbooks, and I'd love to tell you that textbooks are a great way to learn. I can't tell you that. Because textbooks have a real potential to be biased. I write something for a text, and the person who reads it is the editor of that text. So it might be the content editor who makes sure that I wrote things that made logical sense, and then it'll be the general editor who reads it and says, okay, this is what I was hoping that you would talk about. If it isn't what they wanted me to talk about, I may not appear as a chapter in that book, even though we've contracted to make that happen previously. Textbooks have a real potential to be biased. Continuing education, a group like this, there's a potential for bias. I'm hopefully not presenting, and I'm sure Tony won't be presenting, I'm sure David won't be presenting on biased information, or at least we're going to try our best to keep that biased information out. We're going to try to be as scientific as possible. But that doesn't mean that somewhere deep in here that there isn't some bias, some black hole of bad information that we're just not even aware of as we think about it. We have manufacturers' instructions and publications, brochures that are valuable as far as teaching techniques, but may not be the most valuable in terms of scientific information. And the ubiquitous videos that we see, we can go on YouTube right now and find a lot of dental techniques. We can find a lot of other stuff on YouTube. So when we get bored with dental, we can see a few comedy shows. But video sometimes is good, sometimes is not. And the internet, we can probably all have opinions about the internet and what you get off of it and what value there is from it. There are also non-scientific journals, journals that don't go through peer review, and yet they appear to be just as scientific as some other journals. Some journals that publish information that doesn't go through peer review, but it still follows the same general formula of article preparation, and yet there's a bias on the part of the journal to push ideas in one direction or another. I heard a clinician within the last couple months ask me this question: is flawed evidence better than no evidence at all? It's an interesting question, isn't it? Is flawed evidence better than no evidence at all? And sometimes I would say the answer is yes. If someone does a sort of bad study, but they didn't intentionally make it bad, they just didn't gather all the data, they didn't they weren't able to follow things up real well, but it's on a topic that has never been reported previously, there might be some value in getting that information published. There are other times when the bad study actually puts our knowledge in the wrong direction, sort of retards growth of the science, sort of acts as an obstacle for us to learn, and in that situation, flawed evidence is no better than no evidence. In fact, we probably should never see that hit the light of day. Most of the time, the answer to this question is maybe, and sometimes it's we really don't know. And if you don't know, it probably doesn't belong in the literature. We talk about various biases. We realize that there are biases regarding the material that's likely to get published. And one bias is to avoid lies in the literature. That's a favorable bias. We don't want lies in literature. Let's keep that stuff out of the general circulation. But there's about a threefold increase in the likelihood for an article to get accepted if there is a positive, statistically significant difference in the results published in that article than there would be if an article did not show statistically significant results. Threefold increase, isn't that interesting? So if you show something is equivalent to something else, you only have a 1 in 3 or 1/3 the likelihood that that article will ever see the light of day in comparison to an article that showed that one thing was better than something else. It's an interesting perspective. Significant results, just what I said, 3 times the likelihood that it will get published. And the problem in the area of negative results is that researchers quite often lose interest in publishing that information. If they showed, they did a 2-year project and found at the end of 2 years that they had nothing that was superior to anything else that they studied, quite often they just lose interest. And I've seen articles submitted that were clearly by authors who had lost interest in publishing the information. They send in an article because they had a contract that forced them to provide the article, but at the end of the day, they've lost enthusiasm in it, so they write a really bad article hoping it'll get rejected. Any of us who have edited, I think, have probably seen that happen. The thing that is coming about more today is journals are starting to register research projects before the projects are initiated. Or organizations like NIH or other oversight groups will register topics before the research is initiated. And that way, when negative results, either results that fail to show a difference or results that were negative to the product being tested, that information will still get out to the public at some point in the future. That's actually a step in the right direction. We have this issue of bias again. We can manipulate data, we can ignore data, we can provide incomplete data. All of those things fall in the categories of bias. What we're trying to do in the literature is provide information relative to truth. Truth is the goal of science. Ultimate truth is the goal. Do you think we'll ever see it? Ultimate truth? Probably not. It's probably beyond our ability to comprehend. So what we do when we're doing research is we're looking at very specific truth. We're taking truth and we're dissecting it into small little segments. And those small segments are the ones that we're trying to answer questions. What do we know about this? What do we know about that? And how truthful, how honest is that knowledge? Truth indeed should be general, but we're probably not going to get there. So far, that absolute truth is just something that is proven to be very elusive, especially in our fields. So we talked about the types of literature that are out there. We realized that journals come in different forms. We have popular journals, People magazine. The newspaper yesterday talked about, the headline in the paper that was at the hotel said that the patients in South Africa are becoming guinea pigs to the pharmaceutical industry. Headline in the front page of the paper. So that's popular journalism. And I'm sure the article was a little bit less caustic than the headline was, and that's the way journalism works. We have trade publications, and then we have scholarly publications, and those fall into that category of peer-reviewed publications. We also have formal education, dental school. We have continuing education like we have right here. We talk about efficacy, which would be in the world of research, which is this idealized set of interventions. So we eliminate all the patients who have health issues that could lead to a higher failure rate with a certain type of treatment approach. We eliminate those patients, and then what we end up with are results that are oftentimes better than what we can achieve in routine practice. And the reason for that is because we've eliminated all the negative variables. These studies are almost always higher on the evidence-based hierarchy, but that doesn't necessarily mean that they're more generalizable. Effectiveness is what we get when we do case reports, case series, descriptions of either interventions that we followed from the day we started until our current time. And those become what we're using to make clinical decisions. Most of those studies have few inclusion and exclusion criteria. Most often they're performed by clinicians, not researchers, and there are a lot of variables. So it's information to us as clinicians that is very interesting. Quite frequently, it's information that scientists sort of have a dubious response to, simply because there are so many variables that they can't get this specific nugget of truth and feel absolutely confident that they've learned what it is. Effectiveness, therefore, falls lower on the hierarchy. It's more general information, less specific information. And oftentimes it lacks statistical analysis. So why do we not trust the literature? I would say that there's a concept that I'll call the egghead concept. An egghead is sort of that academic who really doesn't have anybody to talk to because they're always talking above the level of everybody else. And sometimes that's what we think of in the literature. I would suggest that it's not necessarily true. There are all these issues of bias, publication bias, author bias, industry bias. We need to realize that literature is harder work than continuing education. And consequently, these are all factors that help us not embrace the literature. So what's real? I'd suggest that it's a difficult question. Often a perception and interpretation. And that's what you get when you read literature. You get that ability to interpret, to perceive. And you find that truth becomes a qualified answer, not necessarily a black and white answer. So I'd like to thank you for this opportunity, and I'll be seeing you again over the next couple days.